So welcome everyone. I'm Kathy Scrimshaw. I'm the medical lead for the Collaborative Mentorship Network, which is a program of the Alberta College of Family Physicians. Welcome everyone that's joined us this evening. We are very pleased to present this session with our colleagues from PEER, Dr. Jessica Kirkwood and Dr. Tina Korownyk, and we'll be talking about back to the basics, reviewing the evidence for management of low back pain. Now, before we get started, I just want to acknowledge that we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 6, Treaty 7, and Treaty 8 territory, and it's the traditional meeting ground and home for many Indigenous peoples. And I just want to take a moment to really reflect on that statement and what we can do in our individual lives and in our practices to ensure that we are speaking truth to power and recognizing the truth and reconciliation agreement that we have with our Indigenous peoples. And so I have already introduced myself. I'm Kathy Scrimshaw. I am a part-time employee of the Alberta College of Family Physicians, and I have no other disclosures. And for the program tonight, we do receive financial support from the Alberta College of Family Physicians through a Health Canada Substance Use and Addictions Program contribution. It does not receive in-kind support. It's presented with the Alberta College of Family Physicians. And so to capture your attendance, please click on the survey link in the chat log to enter your name and email. During the session, we'll be using the Q&A log to collect questions. There's an upvote feature so that most popular questions are noted and will be asked first. Use the chat log to comment during the session. And at the end, an evaluation survey link will be posted in the chat. And we really appreciate you giving us any feedback on the session and more topics that you might want to be covered by the Collaborative Mentorship Network. So the final thing we would like to do is just get a poll of what profession you are. So if you can go ahead and fill that in. Okay, so we got the majority are family docs, and we've got other professions right through. And we'll go ahead and introduce Jessica and Tina, who are going to take us through the latest research on low back pain and what we can be doing in our practices. So take it away, you guys, and I'll be monitoring the questions, and yeah, we'll give you some time for questions at the end of the session, but if you see something that you want to answer right away, just let us know.
Awesome. Kathy, thank you so much. It's such an honor and a privilege to be here tonight with everybody, and we appreciate you sharing your lovely, beautiful Alberta Tuesday evening with us. Tina, I'll let you introduce yourself.
Yeah, so I will start off by introducing myself. So my name is Tina Korownyk. I'm a family physician. I work at the Northeast Community Health Center in Edmonton. I am the director of the PEER team. And so within the PEER team, we really try to avoid any potentially relevant financial conflicts of interest. So I don't have any direct financial relationships with industry. I have received monies from the Alberta College of Family Physicians and other provincial not-for-profit colleges, and I'm also a member of the Canadian Task Force, and I'm employed at the University of Alberta as well.
And my name is Jessica Kirkwood. I'm a family doctor here in Edmonton as well. I work at a place called the Boa-Macaulay Health Center, and I'm also an employee of the University of Alberta and a member of the PEER team. I've also received money from the Alberta College of Family Physicians to speak, and I've done a bit of consulting work with Medical Panel's office, but no industry disclosures from me. And so tonight we're just going to talk to you a little bit about chronic low back pain, and specifically our goals by the end of this session are to help describe the best evidence for the management of this very common condition. We're going to talk a bit about the limitations in the evidence, and as well as identify and utilize some tools for informed shared decision making in the management of chronic low back pain with your patients. And so it brings us to a bit of a painful journey that Tina and I and many of our hardworking colleagues are on. And this journey began in the summer of 2019 when we took on the mountainous task of looking at chronic pain. And within that, we looked at three main chronic pain conditions: osteoarthritis, low back pain, and neuropathic pain. And I actually joined the peer team right in the middle of osteoarthritis, so right when it was about wrapping up. And I was like, oh my goodness, this seems very interesting and also like a lot of work. And so within each of those categories, we're in the process of publishing or have already published a systematic review and a knowledge translation tool as well to help talk to your patients about that. And so what does that actually mean? What did we find in all this work? Well, over 63,000 RCTs have had their titles and abstracts reviewed. Over 1,400 have been reviewed in full, and 290 of those have been fully extracted and analyzed into this work. Osteoarthritis was published in March 2020 in CFP. Low back pain came out in January 2021, and neuropathic pain will be published in May, I believe. And so all of this work is culminating into the peak of this mountain, which will be something we're really excited about, and that's going to be a peer chronic pain guideline. And we're actually in the process of doing that as well. So yeah, really, it's been really exciting. I've gotten like a really great glimpse into what goes into this work, and we're excited to share with you tonight what we found when we were looking at low back pain. So who were we actually looking at? What was our inclusion and exclusion criteria? We were looking for randomized controlled trials, looking at adults with pain for greater than 3 months, looked at radicular or non-radicular low back pain, and we looked for something within the results called a responder analysis. And Tina's going to get into that a little bit more. Who didn't we want in this information? We didn't want kids. We didn't want pregnant ladies, and we didn't want trials that specifically looked at some conditions like infection or cancer-related pain or post-surgical pain. We wanted to just really get a picture of that kind of typical chronic low back pain patient that's going to be in your practice.
Absolutely. Okay, so we're going to focus specifically on the low back pain systematic review that we did. And one of the things, and some of you may have heard us talk on osteoarthritis before. And so when we talked about osteoarthritis pain, what we decided to do as a team was to look at trials that reported patients who had responded. So a responder would generally be considered someone who has about a 30% improvement in pain. And there's a lot of information and data in the literature suggesting that about 30% improvement is when it's sort of clinically relevant. The patient is knowing something. And we're trying to distance ourselves a little bit from these tiny changes in pain that are statistically significant but don't make a difference. So we really wanted to focus on something that we called responder analysis. So historically, a lot of trials looked at changes on a scale. So you'd have a scale of 1 to 10, where 10 is really quite bad and 1 is really not so bad. And they would report these changes, and then you could sort of average them. But it's hard when you're using all sorts of different scales to summarize that. So the responder outcome is really a dichotomous outcome. Did the patients respond or not? And then it's a lot easier to combine that data in a systematic review, which what we were trying to do. So the only potential limitation to that is that not all trials will report a responder outcome. And part of this was we'd love to push the scientific community to include that as part of their outcomes when they're looking at this type of data. So there may be certain trials that weren't included in the systematic review because they did not report that. All right, so we also focused on meaningful pain relief. So a lot of times, and even when I was in medical school, we were sort of taught function is really what you should be focusing on with your patients. But when we look at the literature, the most commonly reported outcome is around pain. And there's some interesting data, a Cochrane systematic review that suggests that when patients present to our office, often what they're presenting about is pain. They're not saying, my function is limited. They're saying I have pain. So we thought this was an important clinically relevant question that we wanted to look at. We said 30% reduction on a scale, but really we sort of had a hierarchy. We would accept 50% improvement, or in some trials, they just reported patients who reached that minimal clinical important difference. And so for instance, in this scale here, on average, when enrolled in a pain trial, people report about a pain score of 6. You know, a 30% reduction of that is about 1.8, which might take you down to about a 4. So that's what we were looking at. All right. Yeah. So what did we find?
Well, I get the exciting job of announcing what we found the most evidence for and the most meaningful pain response in our patients. And that was in exercise. And exercise, I thought you said extra fries, but no, exercise. We found 18 RCTs, over 2,500 patients, and looking at a span of 66 to 52 weeks. Those patients, or the different things that we looked at, it was mostly physiotherapist guided exercises, but these also included yoga, Tai Chi, Nordic walking, which I wasn't familiar with and I learned more about and kind of am interested in getting into, but I think I'd trip myself up with those poles. And most of these trials, the comparators were usual care, education, advice. There was a few trials that gave patients a back pain help book, and then one of them had done like a sham ultrasound. So that would be, I think, a reasonable placebo to compare to in many of these trials. And so what they found was that about 50% of the patients had a meaningful pain response when they engaged in exercise, whatever that may be, versus about 35% in our control group. And that gave us a number needed to treat of about 7. The really cool thing about this is that actually the longer the intervention, the more benefit we saw. And so when we looked at trials that were just 4 to 12 weeks, the number needed to treat was actually quite a bit bigger. But when we looked at those longer trials of 12 to 48 weeks beyond the intervention, we found a greater response in those. So that was something that was really great, because a lot of times we look at these interventions and sometimes they're beneficial initially and that sort of drops off. And that wasn't the case with exercise. In terms of adverse events, those that were reported, things like increased back pain or joint pain weren't statistically significant, and actually withdrawal due to adverse events wasn't reported in any trial. So our bottom line for exercise is that it reduces low back pain when continued over 4 weeks and has a pretty low risk of adverse events, and that the type of exercise likely doesn't matter. And so the figure you're looking at here is one that you may or may not be familiar with, but it's something we use pretty commonly to try to help explain this to our patients. It's called an icon array. And if you looked at 100 happy or not so happy faces, or which would represent like 100 patients, we could say that about 68% of those are likely to benefit. Some of those will benefit from placebo. Some of those are going to benefit from the actual intervention. And it doesn't actually matter where your patient falls, as long as your patient's improving. And I think that our patients and us as clinicians, or whatever work we do, would agree with that we just want to see our patients improve. You may question, where's that 40% coming from? And that we just chose to average the placebo event rate across the board for all of our interventions so that we could kind of compare things. And you'll see at the end what that sort of looks like.
So we should really just stop there, Jess, because that's like we started with the best evidence, which is exercise, and many of you will know that. But it's really, I think it's empowering to see that reinforced in the evidence and in the trials for sure. But I won't stop. I will run through some other interventions that we looked at. And so the next one we're going to talk about is spinal manipulation. So this is one we thought was really important to include, because we certainly have a lot of patients who ask us about it. We have a lot of patients who are doing it and don't tell us about it. And historically, we had sort of seen some conflicting evidence around this. So what we found is 5 randomized controlled trials with almost 700 patients. And the duration was quite sporadic, but went up to 176 weeks. So that's one of the longer trials that we included. So that's encouraging, because one thing we see with chronic pain trials is often they're not very long, which is a bit discouraging. So we found there was a significant improvement in meaningful pain response. And most of these were sort of lumbar spinal manipulation. So 57% improvement with spinal manipulation versus 39% in the control group gives you a number needed to treat of 6. So that number needed to treat is actually reasonably impressive. Now, a couple of things that we noted, and we're going to show you some interesting we think, really interesting graphics later around this. But when you look at studies that were larger, or that had a lower risk of bias, or that had a good sham control, the benefit was reduced. So all of a sudden it wasn't quite as beneficial. And your estimated benefit dropped from about 22% to about 15%. So, and Jessica's going to talk about this with acupuncture, but that idea, so I was the one who actually went through a lot of these spinal manipulation trials. And some of the trials, they did do like a sham. So they would sort of pretend that they're manipulating your back, but they're not. And I'm not an expert in that. But when you looked at the sham control trials, overall, there was still some evidence of benefit, but it wasn't as important or significant as before. So the bottom line with spinal manipulation is really, when you look at the evidence, it may be effective for chronic low back pain. The thing we grappled with a lot as a team is the issue around side effects. And in all of these trials, there was no report of sort of significant side effects, the ones that we're always sort of worried about. So what we did is we actually went, and you'll see a reference at the bottom here, and we went and looked in the literature for other data reporting around side effects. And so there is sort of this observational data that suggests that there could be low but potential risks associated with neck manipulation. So we just thought that's an important consideration. And the majority of these trials that we included here were low back, so lumbar primarily. So that's an important distinction, I think, just when we're talking about this. So again, we have our happy faces that show that with the addition of spinal manipulation, you'll get about 15% more people who will say, yeah, you know what, I feel a little bit better with regards to my chronic pain.
Yeah, and that's going to be a bit of a running theme, as which I found really interesting, was not only looking at the evidence, but also really looking at the quality of evidence, because it's one thing to just take these numbers and kind of pop out a number needed to treat or something, but to actually look at the quality. And so again, I laugh because Tina says, we'll show you an industry graphic. We think that what the work we did is really interesting, and we hope you guys find it interesting too. So talking about oral NSAIDs, we found 4 RCTs that met our criteria. 2 of those were for naproxen and 2 were for COX-2 inhibitors. So over 1,600 patients. And this is where we're talking about chronic pain, and yet the longest trial we looked at was 16 weeks. And so that's where it can be a bit frustrating, because my chronic pain patients, I don't know if it's just that I'm not as good of a doctor as Dr. Korownyk, but my chronic pain patients don't typically not have chronic pain after 16 weeks. That's something that we're likely chronic. Dealing with. Yeah. But within the trials that we looked at, about 55% of patients on NSAIDs had that meaningful pain response versus 37% in control, which gives us that number needed to treat of 6. I feel like I promised, these are real calculations. We're not just making up these numbers that are very similar along the way. But what was a bit more concerning, because we know with oral NSAIDs that there are certain populations that we probably wouldn't want to use them in. I certainly have patients that don't tolerate them from a GI side effect, and yet the adverse events within these trials were not well reported, to the point where it was kind of concerning that we weren't seeing more adverse events being reported, and we were just getting phrases that were kind of like this: withdrawals due to adverse events and individual adverse events were similar between the groups. Like, oh, isn't that nice? And so what we came up with the bottom line was that they demonstrate benefit for the management of chronic low back pain, but the benefits may not exceed harms in some patients. And so really making sure to select the right patient population or who you might want to use. I know personally, I tend to try to more use NSAIDs for when I'm having a flare of pain associated with chronic back pain with a patient, and really saying that this isn't something that I'd like to put you on and keep you on forever. Considering naproxen or ibuprofen would probably be more ideal, as the diclofenac and COX-2 inhibitors may carry some increased CVD risk there. So, yeah.
Okay, so let's talk about duloxetine, the SNRIs. So we were looking for any SNRI or SSRI, but the only data we found was on duloxetine. So we didn't specifically highlight duloxetine for any reason. It's just because that's what we found. We found 4 randomized controlled trials with only almost 1,500 patients. They were all quite similar in their design, about 12 to 13 weeks long. Again, we found a statistically significant benefit with the use of duloxetine 58% of patients in the treatment group versus 7% in the control. Number needed to treat of 10. So there's a couple of caveats with this. All of the studies were industry funded. And with other, one of the subgroup analysis that we looked at is industry funded versus publicly funded trials. And what we tend to find is that the industry funded trials tend to overestimate the benefit. And when you see publicly funded trials, that benefit seems to decrease. The problem is here, we didn't have those publicly funded trials to compare them to. So we need to kind of keep that in the back of our minds. And again, adverse events were reasonably high with the use of duloxetine. So withdrawals due to adverse events, so patients who left the study because of any adverse event was significantly higher in the duloxetine group, so 18% versus about 9% with placebo. So number needed to harm of 11. So the number needed to treat and the number needed to harm are actually somewhat similar. And again, we think that there's some underreporting of adverse events. One would be difficulty discontinuing the medications ultimately. Again, yeah, those numbers may be a bit higher. So most common adverse events that were reported were just somnolence, nausea, and dizziness. So when we, so maybe we'll move to the next slide, Jess. So the bottom line is that it does, based on the evidence that we have, appear to be beneficial for the management of chronic low back pain. There's some caveats, like I mentioned, especially the industry funded trials. And this idea that the harms are reasonably high and may not be, and maybe too high for the benefits. And when the other thing that I'll mention is our team has, we have a committee of physicians and other allied healthcare providers from across the country who have gathered to look at all of this data and to come up with some final recommendations. And so duloxetine is a topic of good discussion right now. And so what we're as a team doing is going back to look at possibly unpublished trials. So one of the ways we can look at publication bias is to see how many trials have been listed in something like clinicaltrials.gov that haven't been published, potentially because they don't show benefit. We don't know. So I would say there's a bit of a caveat on this. We are going back to take a look at that just to make sure, because there are some guidelines currently that are not recommending the use of these medications for low back pain. So we're looking into it, but the current published evidence suggests they are beneficial. And in those trials, they were looking at 60 to 120 milligrams a day. So maybe in certain population in patients with, sort of multiple comorbidities, which we certainly do see, this could be.
Yeah, that's what I'm thinking when I hear you talk, is that primarily patients that I've trialed this on and those that have found benefit are the ones with comorbid mood disorders, for sure. So yeah, but it's really interesting. And I like how it's like, we need to know more. We just always need to keep looking. So
we're not done yet.
Not done yet. So whenever we do these systematic reviews, we kind of get our own, as Tina mentioned, she was on the spinal manipulation group, and I was on corticosteroid injections, which I was really interested in, because we see sometimes these being recommended for our patients. It's something that I have tried for my patients, and I always find it interesting that I will send my patients to these places to get their fluoroscopic guided injections, and inevitably at the bottom of the report, it always says that the patient's pain was 9 or 10 out of 10, post-procedure 0 out of 10. And I'm like, this is across the board. And I'm thinking, wow, like this must be really amazing stuff. Now, when I actually talk to my patients afterwards, they may not have quite the same story, but I find that on those reports, that's really usually what I see. And so I wanted to know a bit more about the evidence. And so we did find 10 RCTs that matched our inclusion and exclusion criteria, over 1,100 patients. Again, really wide range in terms of follow-up. And I also have on there that methods varied greatly, and I really mean that. And just to stress that, it was, I don't even know if there was 2 out of those 10 that were quite exactly the same, in that we had epidural and local injections, sometimes containing lidocaine, sometimes not. Typically the placebo was another injection, whether it was lidocaine in both arms or whether it was a saline injection. And even just the difference between single versus multiple injections in the trial. That varied quite a bit, to the point where some trials just said everybody, the intervention arm received an average of this many, and you couldn't even narrow that down into, well, does that mean somebody got 1 and another person got 20 injections? Like, where is this average? What does that mean? So it really left us asking a lot of questions. And then when it actually came down to looking who benefited from these, well, about 48% of the patients that received corticosteroids noted pain relief, and about 45% was placebo. And that's not a statistically significant result. So the act of just like breaking the skin and poking someone seemed to also have an effect. When we looked closer at quality, when we were doing these subgroup analyses, there was no effect in larger studies, longer studies, or non-industry funded studies, and not with any the studies that we classified as having a lower risk of bias. And again, when we're talking about reporting of harms, withdrawals due to adverse events was not reported, and other harms were just very poorly reported or not there at all. So our bottom line was that corticosteroids for low back pain appear to be no more effective than placebo, which again, placebo has an effect, but when we think about things now, at least for my patients, I'm not having any cost associated to them to have these shots booked, but there is a cost to the system. And I have to consider that when I'm arranging these interventions for my patients. I still kind of, because I've done this for patients before, and again, we get these reports and things, I wanted to take a look at, is this consistent with what other people are saying in terms of corticosteroid injections? And this was pretty reassuring. Dr. Chow is fairly well known for doing chronic pain and particularly back pain evidence reviews and guidelines. And in BMJ Clinical Evidence in 2010, their statement was, we don't know whether epidural corticosteroid injections or local injections with corticosteroids and local anesthetic improve chronic low back pain in people without sciatica. So kind of looking at different groups there. And that facet corticosteroid injections may be no more effective than placebo. So that's really consistent with what we found. And then the NICE guidelines that came out in 2016 also said, recommended against offering spinal injections for managing low back pain. So, okay, like I feel pretty confident in terms of what we found and how that compared to what other groups have found as well.
Yeah, for sure. So opioids, here's another, and this is what led us into the chronic pain world, is when we received a grant to look at opioid use disorder a few years ago. And part of that was an agreement to look at how do we manage chronic pain? Because I mean, you could argue there's many reasons we had an opioid crisis, but one of them may have been that opioids were being prescribed for chronic pain of any sort. So we found 6 randomized controlled trials of over almost 3,000 patients, following patients for 4 to 12 weeks. So 3 of the trials looked at an opioid alone. 3 of them looked at a combination of something like tramadol, acetaminophen, something like that. And they were all randomized to that versus a placebo. So we did find a statistically significant benefit in those receiving the opioids, so 39% versus 32%, with the number needed to treat of 15. A couple of things with this data. The withdrawals due to adverse events were very high. The number needed to harm was 5. So the number needed to harm was higher than the number needed to treat. So this is patients pulling out because they couldn't tolerate it. And specific adverse events, most of you will be very familiar with. So the other thing that made us pause for thought is just, again, the duration of these trials. So the longest trials that we identified were 12 weeks in duration. And we do have data that we won't publish, and I maybe have referred to before. We had a student who was looking at opioids for all types of pain. And she was looking at different time frames, and what her data suggests is that short term, so 4 weeks or less, demonstrates a benefit. 4 to 12 weeks, less of a benefit, and then over 12 weeks, actually trended towards harm. So based on that piece of information and this piece of information, that this data isn't really very long enough to give us that information for chronic pain and their significant harms. Our bottom line with regards to opioids is, Jess, if you just want to flip the slide there. Oh, sorry. Yeah, and here's, so this is the, I told her I wanted a metagraph just because I love metagraphs. We don't have many, but basically the top is the opioid only study. So you can see opioid only was borderline, but not statistically significant. The combination of an acetaminophen plus an opioid did show some slight benefit. When you combine them all together, it was just borderline. So you could argue, if you were, a purist, that there was a statistically significant benefit there. But like we said, our conclusion was that the harms in most cases probably outweigh the benefits. Again, all the studies that we identified were industry sponsored, inconsistent quality of evidence, and no trial reported data beyond 12 weeks. So there may be a small benefit. However, long-term outcomes are not clear and a high risk of adverse events. And as Jess was talking about, other current guidelines will suggest, so there's the American College of Physicians guidelines, there's the NICE guidelines, even some other smaller European groups that suggest don't use opioids for chronic low back pain.
Yeah. And I will argue with you also when you say we don't have many metagraphs. We only have one in this presentation, but if you refer to the appendix on any of the SRs we've done, there's about 1 million metagraphs. You could cover your office in the walls, Tina. Maybe we'll do that for you.
Thank you.
So I'm going to talk a bit about acupuncture. And so within acupuncture, we found 8 RCTs, quite a large number of patients, as you can see, over 4,600, with a duration range of about 4 to 24 weeks. Initially, so the primary analysis, when we looked at everything, found that about 54% of patients that underwent acupuncture reported a meaningful reduction in pain versus 35% control. There's that number needed to treat of 6 again. But you'll see this is a little teaser to our fun little figure at the end, where we're looking at, okay, that big blue dot is our primary analysis, but when we did our subgroup analyses and we broke things down into longer trials, larger trials, low risk of bias trials, there actually was no effect in any of those. And then this gray dot, where we're talking about true sham, that is this idea of, if I enter into an acupuncture trial and I'm randomized into getting acupuncture or going on a wait list, I'm going to feel pretty confident. I mean, unless, I don't know, unless I'm really tired or who knows what's going on, I think I'm going to know which intervention I got or that I received an intervention. But there are true and validated sham for acupuncture, which I found really interesting. It's kind of like the uncle, like the uncle's, oh, I got your thumb trick, or you got your nose trick, because it's like this little tube with an acupuncture needle, and the tube goes against the skin, but as the recipient of the treatment, you don't really feel whether or not the needle pierced your skin. And so you're getting some sort of palpable intervention, but you're not truly getting acupuncture. Another form of sham is that they just kind of stick the needles in random spots, but they don't put them in the actual locations where the acupuncture should occur. And so I think those trials, and as a team, we feel that those trials maybe more truly represent the effect of acupuncture. And in that case, the benefit decreased significantly, showing that about 62% of people that got acupuncture versus 57% of that true sham. That was the difference. And so that number needed to treat increased to about 20. And so I thought that was really interesting, which brought our bottom line to turn into the kind of this gray face picture, which is acupuncture for chronic pain may work, but how well is really still unclear to us. And that when we looked at these multiple quality markers, that's when effects were really reduced. And certainly that idea of having a true sham, because when we look at other trials and we're using placebo pills that are very similar, it's trying to compare that as best as possible. And that's when we really saw the effects decrease.
Awesome. Okay, so I get to talk about rubifacients. And the only data we found was on capsaicin. So we found 3 randomized controlled trials looking at its use in low back pain with over 600 patients. They were all very short term, all 3 weeks or less. I don't know if the patients just couldn't tolerate it anymore, but that was it. And they did find statistically significant relief in pain over that time period with an M-needed to treat of 6. Now, Jessica points out a good point. The adverse events most commonly reported were heat sensation, but she was like, well, not.
I thought that's what it did. Like, I thought it would be like if I was like an adverse event of tiger balm was like a heat, like that's yeah. What's happening. So
it makes you feel hot. Yeah. So number needed to harm. But the trials withdrawal wasn't reported, so we don't know how many people couldn't tolerate it at all. So there's limited evidence on the use of capsaicin for our patients. And I was I I'm going to bring it up. I was talking with Jessica
Oh.
in a PBL module on, I think it was vulvodynia, where they had mentioned that you could consider capsaicin. And our whole group just thought, that doesn't sound comfortable at all. And then shortly after they sent out a retraction that maybe we didn't mean that. So
I thought, man, people in pain will really try anything.
Yeah.
Especially vulvar application of capsaicin does not sound like something I'm going to recommend to my patients. So yeah.
Yeah. So the bottom line was it's not clear because the longest data we have is 3 weeks. And the other trick with this is you cannot blind these trials because patients are going to know due to the common adverse event what they're getting. And the reason we included these, and we'll show you the decision tool, is this idea of shared informed decision making, just being honest with the patient, saying, you know what, this is the best data we have. And in primary care, we know that there's so many areas where we're just working with limited data. So just to put it on paper and say, this is what we got, this is it.
Yeah. And to further that, in terms of interventions that we looked at that had limited data, there was 2 that only had 1 RCT. So again, when we have things like this, we can certainly look at the quality of the evidence, but we can't really compare it. We can't do subgroup analyses or anything. And so anticonvulsants was one group. There was 1 trial with 108 patients looking at gabapentin, and about 22% of patients that received gabapentin versus 26 with placebo, and so it received that meaningful pain relief. And so that was a not statistically significant result. One thing that's always concerning with gabapentin is the adverse events. And so we certainly saw more withdrawals due to adverse events. And then looking at significantly increased numbers needs to harm with fatigue, dry mouth, the dizziness, loss of balance, concentration. So we will be talking a lot more next week about gabapentin and other anticonvulsants when we talk about neuropathic pain, because while they weren't found, we didn't find very many trials for chronic low back pain. We found a very large amount of trials for neuropathic pain, but I will not provide any spoiler alerts because we want to see you back next week. So, but you'll certainly hear more about that. And then in terms of topical NSAIDs, this was a bit of a bummer because I would have really liked to have had a bit more to go on than just 1 trial with 127 patients who 62% reported benefit versus 52% with placebo, and that was also not statistically significant, and no difference in adverse events there. So not to say that trying a topical NSAID isn't reasonable, it's just that we don't have this higher level evidence to really make any sort of comment on that. And then even more disappointing, no studies identified for acetaminophen, though keep in mind that the acetaminophen did show no benefit in our osteoarthritis studies. And I'm really sorry, I know it's 420 today, and so there might have been people who really thought they were going to get a lot of information about cannabinoids from us, but Tina's like, what? 420? But yeah, we had no studies for that, though Peer did come out with a prescribing cannabinoids in primary care guideline a while back, so you can certainly look at that. SSRIs and TCAs are another one that we found no evidence for, as well as that really relaxed kitty cat on his muscle relaxants. No studies there. So womp womp.
Yeah.
So
right.
Tina.
Yeah. Okay. So this is my favorite slide. This is it. This is the pinnacle right here. So and so part of we did not do this with our first systematic review, but with the second one, we felt like we were forced to, partly because what Jessica said, it depends how you look at the evidence, will change the value and the bottom line. So for instance, what I'll do is I'll maybe pull up the acupuncture. The acupuncture one is a pretty impressive example of that. So the big blue circle is a summary of effect of all studies, right? Oh yeah, Jess has got circle.
Can I do it?
Thank you. Yeah, you are. Good. I thought I was, but I forgot I don't have Yeah, so you're absolutely, thank you. I was just showing myself. So the blue circle absolutely shows you the benefit of all the trials. And if you look on the left-hand side, so that scale there is the absolute increase in patients receiving a 30% or more pain reduction. So remember, that's above placebo, right? So placebo effect on average is about 40%. So 40%, no matter what you give them, they're going to say, oh yeah, I feel feel better. But then above and beyond that, say about, 22, 23% of patients in acupuncture were saying that. But all of a sudden, when you look at, so the purple dot is the publicly funded study. So in that case, it wasn't that much different. But in other things we've looked at, that is quite different, actually. If you look at the X, so, oh, sorry, Jess.
I was just going to say, and also just to point out that in areas like oral NSAIDs, in the rubefacins, in opioids and SNRIs, we just had to say there are no publicly funded studies in any of those. And so that's where that is marked. Oh, my mouse got very big. Yes.
Yeah, absolutely. Because so if you went to the orange, so orange, for instance, an X means it's no longer statistically significant, right? So all of a sudden, if you looked at studies that were longer in duration, it didn't seem to demonstrate benefit. If you looked at studies that were larger, so our cutoff was 150 patients or more, because there's some evidence that shorter studies that are smaller, they tend to over demonstrate benefit. The gray is the sham controlled study. So all of a sudden, if you introduce a sham, your benefit, falls by half. Because people just like to think something's happening to them. So was it the acupuncture or was it just the intervention? And similarly, so as you go across there, you can see the value changes a fair amount depending on those different interventions, for instance. So that's why when you look at, you'll see all sorts of data that will suggest the X's will say not at all significant, and then the circles would say it was statistically significant. So this really, I don't think we would show our patients that, but for us as clinicians, it helps underline why there's so much confusion and so much sort of controversial data on this. And it depends on, and these are only some of the things we've looked at. There's certainly other ones too. So if anyone has any questions about that or comments, I'd love to chat about that.
I feel like I saw that there was a hand raised, but I have no idea what to do about that. So then what I'll say is we're only a few more slides away from being into time for questions. And so I'll be looking in the questions to answer your questions. So I'm sorry, I don't know how to like unmute anybody or anything, but we'll definitely answer questions about that because this is new for us too, trying to find a visual representation. And I won't even try to explain how many renditions we went through on this and how to show this. It was really interesting.
Exactly. So this is a summary, and actually, I think this might address I saw one of the questions in the list of questions was, I think adjusting what Jess said about the similarities of the percents for meaningful pain relief. So I'll kind of run through this. We just put this in. How we ordered it here was in our confidence or certainty of the evidence. So we had things that we thought the evidence was of moderate certainty. So looking at all those different factors, looking at risk of bias, what have you. So we felt like exercise had a moderate certainty of evidence. There was 18 RCTs. You can see the percent benefit over control or placebo, and then the risk ratio. So exercise of all had the best evidence of benefit. Then oral NSAIDs, again, we just thought those studies were reasonably well done. Similarly, the duloxetine ones, even though we're still curious if there are unpublished studies, of no benefit, which we'll just confirm. So then we move to lower evidence of benefit and very low certainty of the evidence. And it will show you. So one thing that I think is fair is that, and is actually somewhat reassuring, is that the placebo event rate, so this rate here, is similar across a lot of interventions, right? So we said on average it's about 40%. So we, some people, would say, oh, placebo rate's about 30%. I think the placebo rate also tends to vary what intervention you're looking at. So in the chronic pain world, it seems on average about 40%. And so then these numbers here are just showing you the additional benefit over placebo you would get with those interventions. So you can argue, I mean, there's none that are sort of blowing you away for sure. And they are somewhat similar, but it also, there's a great review that talks about this as sort of the rather sobering data we have on what we can do for chronic pain management.
Yeah. And so then another part of just putting our evidence into tools that clinicians and practitioners can use is this one pager. We call it a one pager because there's this side and then the next side I'm going to show you. And then for this one, because we had looking at the different qualities and everything, we actually made it like a 3-pager, or like a 1 and a little bit more pager. But if I know some colleagues and peers have taken this out of CFP or printed it or whatever and had it so that they can show their patients. And then I'll also show you an online tool that you can use as well to just compare all these different interventions together. And it is frustrating when we have to put like a question mark with gray on it, but we don't feel confident that we can really make a strong statement when you can see all the different limitations within the evidence. On the other side of that handout, we have a bit of a table to go through. Again, sort of ranking where we feel things landed, looking at what some of the adverse events would be, the cost, which is always important, and a few just prescribing comments on there. And so, yeah, another option to discuss this with your patients, I will pull up this pain calculator on the screen because it's just right there in the office. And I'm not very good at keeping papers. And so what we've done within the pain calculator is we've broken it down. You can see our 3 categories are neuropathic pain, osteoarthritis, and back pain. And next week when we talk about neuropathic pain, I'll take a bit closer of a look into breaking down what is all available, but I do strongly recommend you check it out. You can look at each intervention individually, looking at risk factors, looking at different things. And then there's also a page that compares all of them against each other, kind of like that handout that we created. Yeah.
Okay. Oh yeah. So this is and there's a couple other great. I was just scrolling through the questions. So our guideline committee has identified 10 additional questions that we are currently in the process of trying to answer to sort of round out some of this data that we're presenting to you, because as some people have identified, there's still some questions they'd like to know. And one is around the idea of prevention. So if a patient presents with acute pain, can we prevent that development of chronic pain? It's tricky, but there is some interesting data there. There's 2 more on exercise. So I saw people had identified that. So we are taking a very in-depth look at the different types of exercise, resistance versus aerobic, trying to really get, the evidence around that. We've seen some systematic reviews that suggested it didn't make a difference, but we want to dig a bit deeper into that. So we're looking at that, and then looking at motivating. How do you motivate patients to exercise? Because that's a big thing. We know it's the right thing to do, but how do you get your patients there? Psychological interventions is another big one that Jess is looking at. And then additional topical therapies and cannabis. Our guideline committee, there's just so many questions about that. So we're just updating our look at the data on that as well. So those are things. I saw there were some great questions about that, and we'll have better answers for you in about 6 months. So
and yeah, just a really quick reminder before we get to the questions that we're back again next week to talk about everything that we found with neuropathic pain. It'll be on Tuesday again at 7 p.m. And I imagine that the link is probably in the chat. Now, as we get to questions here, because I'm sharing my screen, I can't see them as well. So Tina, if you saw one that you just have a burning desire to answer, grab that first. Or I know Kathy, you were going to maybe jump on and help us. We've got 13. How exciting.
Yeah, and we got Drake started off, and he's got the most votes for his question. So I'm going to start with that one. It says, for exercise, were patients supported in a supervised exercise program or told to exercise independently? And he comments, my fear is that if we simply tell patients you need to exercise without supporting them in that journey, is it going to be effective? And yeah, so I'll throw that at you.
Yeah, and so as I say, most of them were physiotherapy led, most of the trials that we looked at, but there were some that were independent. And I always have to think in my mind too, that even just the act of being enrolled in a trial may be more support than what an average patient would have if I just said, well, you got to exactly, well, you need to exercise. That's the thing that has the best evidence. Look at this, beat it. So just, and that also being motivated in a trial, or being enrolled in a trial indicates that someone's motivated. Like that's huge, right? Yeah. So yeah, and as Tina said, that our additional questions, we do have one where we're looking at what are the best ways to engage and motivate patients, looking at motivational interviewing and things like that. And though there's tons of evidence out there that needs to be sorted through, it's going to be interesting to see what we find.
For sure. And then the next question is from Michaela, who is a physiotherapist, and just commenting as a secondary provider. seeing many low back patients, received imaging from us, usually as family docs. And even though the evidence shows that that's probably not indicated unless there's red flags, that we're always aiming for diagnosis, and that this seems to have significant impact on how patients perceive their pain is what I'm interpreting there. And they're often negatively primed by the time physio gets them to this kind of pain journey. And so I guess we're asking your thoughts on this. And then there's been a discussion back and forth with some other within this chat, because it's so true. And how do we change that imaging? How do we change the demand of our patients asking for imaging? Yeah, all that piece. And how did that come out in your review of the literature?
So I'll jump in first. So obviously, Michaela, that's a great point. And I think everyone's just liked it because they're like, yeah, we agree with you. And we, and certainly there's lots of good evidence on that, right? So you hit the nail on the head. You image patients who don't need to, and then they fix it on that, and their pain tends to be worse long-term. Because I mean, yeah, of their degenerative disc disease, I think, right? So I absolutely agree, but yeah, Kathy pointed out some great, points, is that the patient's expectations, and it's complex. But I do think you're right. If we could strengthen our approach to management of pain and the messaging around that, then perhaps we could limit that piece of it. Because I think sometimes primary care docs don't even know I don't know what to do. I'll just send you for an x-ray, and that's a bit, which is terrible. And I think, I don't know. I mean, we've been trying to get that message out, and I think Choosing Wisely says the same thing, for sure. But you're absolutely right. We need to work on our approach to low back pain. And maybe, go ahead, Jen.
I was just even looking in the guidelines, when I was looking to see their message regarding corticosteroid injections, a huge message within there is stop x-raying these backs, stop sending these people for unnecessary imaging. But I love to hear it from a physiotherapist. It's like, you're really not helping us out anything. When this person comes, they're like, look, I've got degenerative disc. Like, look at this. You're going, like, it's really challenging when they have this sort of, I've got this thing wrong with me now. And it can be a huge barrier. So we just need to keep working at getting that message out, for sure.
Yeah, I always equate it to, osteoarthritis, when we go, it's bone on bone, and everyone's like, and so, yeah, we need to change our message for sure. So we'll keep going here. We had a question about, it actually was in the chat from Sana, was asking about the dosage for duloxetine, because Up to Date says maximum effect is at 60, and you mentioned 60 to 120. Any comment on that? And there was a second question, if there's other SNRIs that are effective, or did you find, and it sounds like you didn't find evidence for them, but.
Yeah, so I'll jump in there. So yeah, we looked for any SNRI and duloxetine. I mean, maybe it's like the makers of duloxetine are brilliant, because they are doing trials all over the place in all sorts of different niche areas. So they're the only ones, as far as we can find, doing trials on this. So we don't know if other SNRIs would have a similar effect. They may, we just don't have that data. And the dosing, our mantra is always lowest dose, because then you're going to have the best effect with minimal side effects. And duloxetine has high side effects, which you probably even noted in your own patients, right? The nausea, whatever. So we included those doses just to show you what's been trialed in the trials. But my personal bias, and this is just the bias, is that I would always start low, and then there's always room to move. I don't know, Jessica, you have anything to say?
No, yeah, 100%. I couldn't agree more. And I think that's why too, we highlighted that those were the doses in the trials, despite the fact that those typically aren't the doses that our patients can tolerate.
Yeah. Okay. And then another question was with the exercise piece. I understand the type might not matter, but they were curious if the trials looked at one type of exercise more than another, aerobic. And I think you answered that a little bit. It's further questions that you're going to be asking, but any comment on that just from your preliminary look?
Yeah, no, not that we could see was that there was anything that was far and above more beneficial. Yeah, I think
Okay.
just moving our bodies, just in whatever is going to work and be something that you can incorporate into your lifestyle. I don't know,
Great.
Tina, if you have anything more to add, but
Yeah, that's the problem. And even now, as we're doing our further dive into it, there's just trying to, because there's a million different things you could call exercise, and how do you categorize those,
yeah.
and trying to find some groupings that will make sense and provide us with some information, as opposed to saying, oh, there's nothing. So we're working on it.
Great.
Mm-hmm.
And so Mary asked, did you see any timeline cutoff on spinal manipulation? The studies you reported go along with the experience she's had with patients going indefinitely, getting temporary pain relief and going back for readjustments. Is there any evidence of permanent relief?
Sorry, I didn't mean to stop showing my screen there. It just
Just
a malfunction. I can bring that back up.
Yeah. No, it's a really good question. A lot of the trials just say they were administering spinal manipulation for 12 weeks. Their last report of pain would be at 12 weeks. So that question of sustained relief is not well answered, I would say. And it's I totally agree with you. Trying to parse through that is difficult. And I will just add on, there was a question about who is doing these spinal manipulations. I did see that. And I quickly looked back, and so it was a little bit of everything. So there was some chiropractor led, there was physiotherapy led, and osteopath. So those, yeah. So again, there's quite a variety in how they were being led.
Okay. And Drake was asking about chronic pain education. It's been more common teaching patients about the nervous system, neuroplasticity, pain originating in the brain and taming it. Any evidence for that type of approach for managing chronic pain?
Yeah, so that's going to fall into the question that I'm currently working on with another one of our colleagues from Manitoba. And so far, all I can say is that there's a lot out there, and it's going to be really interesting to see what we find. But looking at within that, yeah, education, and also CBT and mindfulness and ACT and all the different types of education and psychotherapy involved. But specific evidence, I can't tell you right now.
Yeah, and I just wanted to comment. So Drake, you're likely familiar with a lot of this stuff that our committee was just talking about, that Tame the Beast video that just sort of talks about chronic pain, which is, if anyone hasn't seen it, it's kind of a fun one to Google. So Tame the Beast, because it talks a bit about that. So we haven't looked at the evidence on that. We're in the process, but yeah, it's a great point.
Mm-hmm.
Great. And then we have another question. I'm quite hung up on the similarities in MPR numbers. Can you comment on why you think they're all similar?
So I think I kind of talked to that a little bit, like that meaningful pain relief. I think, if I answered that correctly, just that a lot of them are like 50 versus 30, or 55 versus 35. And I just think it's because placebo event rates are fairly consistent, and we're just seeing limited kind of benefit with a lot of these interventions.
Okay. Thanks. And then we did answer that, who was providing the spinal manipulation. You looked up that one.
Yep.
And there's a question, did any of the reviews look at the benefit of IMS with dry needling by physiotherapists?
Because I want to be able to, I think that was how I kind of lost my screen there, was I wanted to switch over to look at the table of all of our included acupuncture trials, and then I ended up losing my screen because I'm just trying to remember now for acupuncture. I don't know if you will, Tina, if we included any needle that pierced the skin. So that included acupuncture, dry needling, electroacupuncture. I think
I'd have to look it up. Yeah, good question.
Yeah, I'm not 100% sure. So yeah, I don't know. I think dry needling fell within what we looked at. We kind of grouped it all together, but we weren't able to like do a subgroup analysis of acupuncture versus dry needling, or yeah. And it's actually interesting. Next week we'll talk about it for neuropathic pain. I'm excited to talk about that because little bit of a spoiler, but there was 3 trials included in that, and they were all very different with very different comparators too. So it's really hard to summarize that. Yeah.
Okay. And Drake's got another question that just got upvoted here. Many of these are physical interventions. Which chronic pain is involving the mind-body connection, nervous system? Any recommended holistic therapy? And I think you're looking at CBT, ACT therapy, mindfulness, etc. And so that's to be coming soon or in 6 months kind of thing.
Yeah, certainly. I'm hopeful. I'm always really hopeful when I'm given these areas, and then I start to look into the evidence, and it's really challenging to try to compare. But I'm working on it. I promise, Drake.
Yeah,
I'll
and
do
he
my
did
best.
that. Yeah, he did add a comment to add to this. This might be why placebo's so high in interventions. Brain literally, sort of releasing endorphins, and any intervention or support is viewed on as being supportive. Yeah. And just a plug, we do have sessions in May on ACT therapy if anyone's interested in that. Acceptance and commitment for both addiction and chronic pain. So yeah. So did any of where did sciatica fall within your low back pain studies? Did it fall into any of the evidence that you were looking at? Was it a subgroup?
We didn't subgroup for sciatica, right, Tina?
Yeah, we had some great discussions
Yeah.
around so we were specifically looking at, so it had to report a low back pain, and like we said, radicular and non-radicular was okay, but
that was often the limiting. Yeah.
Okay, fair enough. And can you comment on the opioid doses that were used in the trials that you examined?
I will have to look that up again. I cannot at the moment.
Okay, I actually know who that's from, and so yeah, we can send it out with a link. Yeah. Okay. And I think you answered this question. There was sham needling, like with the little tube, and
well, that's the thing that varied so much, but
okay.
Yeah, depending, sometimes they would just like, and so dry needling, for those people that don't know, because again, I learned a lot about the acupuncture world, and just how different things can be in trials. But dry needling is when the needle is inserted and then like moved around a bit more. And I think I can probably be corrected in the chat, but talking about like breaking up fascia and stuff like that. But yeah, Joe's saying here how there's no way to sham dry needling. So like, again, this would be an intervention where if that was happening to you, like a needle being inserted and moved around, like you're likely going to know that that's happening, versus, somebody like tapping on your shoulder. Or there was even ones where it was just like ultrasound provided. So yeah,
Okay.
The idea of being able to blind participants is really challenging in these interventions that have some sort of like physical manipulation or intervention in some way.
Right.
Yeah.
And Ted Finley had a question. Did you find any different evidence for the use of epidural corticosteroid injections, specifically in the presence of radiculopathy?
Yeah, no, not within the group of trials that we had. There just wasn't even enough to be able to group together to say these ones were in the presence of radiculopathy and they showed an increased benefit or a decreased benefit. There just wasn't enough consistency. Like I say, even just trying to group them into which ones are single shots versus definitely multiple shots versus maybe multiple or like it was, bits of a Mod Podge.
I mean, it's so interesting, right? Because all the spine clinics tell you to do it. Yeah. So interesting.
Yeah,
evidence is not strong. Not there. What was the longest follow-up period? And I think there was long in chiropractic, but was with the interventions, and definitely is the limitation that I'm hearing in the evidence that we have chronic pain, but the trial's 12 weeks.
Absolutely. And I mean, they're saying there, I wonder if follow-up was at least a year, if there'd be any true effective intervention. And wouldn't that be nice when we're dealing with a condition that is lifelong for many people, if we had evidence to say whether or not something worked beyond this, 12, 16 week window. So yeah, I think that was that spinal manip that had the 176 weeks.
Yeah, and then followed by exercise, right? So exercise had
Yes.
52-week follow-up, which,
Yeah.
as you alluded to, just that was and it was the only one where it seemed like, well, one of the only ones where it seemed like benefit increased with
As
longer
the trial length. Yeah.
Okay. And did any of the trials look at combinations of interventions?
There were certainly many trials that had combinations, but due to the fact that we wanted to try to look at a true intervention versus placebo, that was really tricky. So are there trials out there looking at a combination acetaminophen, oxycodone versus duloxetine and an NSAID? It's really hard to parse out where benefit is coming from, but one of the guideline questions was looking at combination therapies, right, Tina?
Yeah.
And so I know we've got a couple really strong team members that are trying to take a peek at that, though really challenging to compare, right?
Yeah.
Yeah.
So just a quick comment on that. We had the only reason we agreed to take it on is because NICE had a review on that, and they had one review that was 800 and some plus pages trying to look at combination therapies for pain. So that's an insane project to take on. So we initially wanted to just look at single interventions, and that was a lot. So we're going to try to look at the combos, utilizing work that other groups have done, and then just supplement it with newer trials that are needed.
Yeah, because I mean, it is a challenge, right? Most of us will have patients on 1 or 2 or 3 drugs, or, physio plus, all those things. So yeah, parsing it out will be really important. So I think we answered most of those questions. I hope I didn't miss any. There was a comment just on Ted's question. Mark said, I think the slide indicated sciatica was a criterion for exclusion from the corticosteroid.
Just the sciatica alone. Yeah. So like radicular back pain, meaning like back pain that originated at the low back and that radiated was included, but sciatica alone, so like only those lower limb symptoms, they would have been an exclusion. Yeah.
Okay. Okay.
If that wasn't clear.
That looks good. And another comment, looking forward to hearing more from the review into additional questions, especially around exercise, psychological interventions. Will meditation be included, and yin yoga, which could fall into both of those topics. So thank you. Yeah, so lots of great information. I think we'll all be looking forward to what interventions we can. It can get a bit discouraging when you look at the tool and you show your patient and they're like, really? So yeah, it was great to have you guys. And just a shout out for next week's neuropathic pain. And in May, keep posted. The CMN will be sending out invitations. Vincent Lamb will be talking about ACT therapy. And if you haven't read Bloodletting and Other Miraculous Cures, which he wrote I think when he was a resident or in ER, at least an ER doctor during SARS, it's really worth reading again. And we will have a CMN only workshop on how to do ACT therapy in a busy family practice or primary care practice. It doesn't have to be a family doc, but a team member too. So just want to thank everyone for joining us, and hopefully we'll see you guys all next week.